All right. So for those who I haven't met, my name is Weston Ferrer, Dr. Ferrer, but really Weston's fine with most of you. I'm a psychiatrist, and I did my training at UCSF many years ago and went on to join the faculty and specialized in anxiety and OCD. And so this has kind of been my main focus ever since. I meet with a lot of therapists now because now I'm in private practice and kind of doing this full time. And a lot of therapists that I work with, and actually, Gian, if you could let people in along the way, that'd be great. So a lot of the therapists I work with often have questions about kind of what do we do as psychiatrists, how do we pick a medication, or having conversations with folks around medications that feel tricky and sticky, just like I have conversations with patients around the therapy and how to reinforce what they're doing in the therapy and the questions they're having, et cetera. And so it's just been nice to have kind of bi-directional conversations around this. And so for my part, I went ahead and put together just a little bit of a talk on some of the questions that come up the most that I think that the therapists often find helpful. And what I'll do is I'll save time at the end for Q&A if that sounds good. Okay, let's do it. So psych interventions and OCD, and we'll top in. And if you guys have any questions about what I do and where to send patients, there's my website at the bottom, which is anxietyreliefclinic.com. I am seeing people fully via telehealth, taking new patients, and I'm in California, New York, Florida, Colorado, and Washington at this time. So the first and most basic question is just who gets referred to psychiatry? I feel like this might be kind of one of the easier ones, but it's actually worth exercising our brains a little bit about like who's the right person to refer to begin with. OCD is certainly a subspecialty disorder, meaning that it's not something we would ever expect a primary care provider to manage. And the reality is most psychiatrists also aren't really prepared to manage it that well either. It is something that we get very little exposure to in training, no pun intended, just because it's not actually a big part of most training curricula or like a required rotation or anything like that. And so people get some degree of access, but a lot of people never really see more than 2 visits or something with OCD. So it's hard for most psychiatrists to really kind of get their hands around it. But who do you want to refer in general, and especially to a subspecialist? So one is, even for people who aren't interested in medication, if there's just a need for some additional, sort of fresh set of eyes to think about the diagnosis, that can be really helpful to send folks to us, particularly if you include that as a question, right? So if you let us know, hey, I'm very interested in you seeing this person. They're not at all interested in medication. I think that's fine or whatever. But it's just a little tricky, this case. I don't know, is this illness anxiety disorder or OCD or that type of thing? Just a fresh set of eyes can be helpful. And so myself and others are happy to do that. And it tweaks our evaluation a little bit to put it through that lens. And we might ask different questions to really try to hone in on answering that question. But for the most part, of course, most folks we see, it's around the medication piece of things. And so then who's the right candidate for medications in OCD? I like to keep it interactive. So what are some of the things that you guys think of?
I think if there's a certain level of symptomology, where it's like to the point where even going through the therapy, they're just suffering so much, and you think, medication could really kind of turn the volume down on this and give them some relief.
Absolutely. Yeah. So moderate to severe cases are usually the ones that we think about in terms of medications. I love to use one of the buzzwords that we get all the time, which is like turning the volume down. That's an excellent way that I also use to describe the impact of medications and treatment. 2 of the flags that I look out for is like a good opportunity to think about referring someone to psychiatry. One is folks who have high levels of avoidance patterns, which a lot of folks with OCD have, but it's varying. But people with high levels of avoidance often have a really difficult time getting into ERP because they are so used to avoiding that they just don't want to deal, they don't want to go in. And usually we don't get very far and can sometimes scare people out of treatment entirely if we don't get some medications on board to help them to be able to tolerate it a little bit. Now, I don't think that's the only approach, but it's often, if nothing else, a flag that we'll probably end up getting there eventually. The second group is folks who get stuck. So you guys have seen this a million times before. People who start off, they're really determined, they're making progress, and then they either stop doing the exposures because they start avoiding, it becomes too much, they won't do it, or they're doing the exposures, but it's just not really providing a lot of relief. which happens, right? We like to think about ERP especially as this like panacea, but it's imperfect, just like any modality of treatment, medications, therapy, or otherwise. And so there's sometimes people who just get stuck, or even if you're trying a different approach besides ERP, the progress just gets limited. And so those are great folks to consider for medications. And so I'll also forecast that with patients at times who are maybe even on medication, but a relatively low dose, but they're focusing on the therapy. So that's great. If you feel like you get stuck at some point, call me, basically. And that's a good time for us to reevaluate. So this is kind of my favorite part, which is like commonly asked patient questions. So these are things that I hear over and over and over again. I'm sure that many of you do as well. And so it's nice to sometimes get these questions out ahead of time so that you guys can have some answers prepared when they're asking before they come to see us. Because of course, unfortunately, a lot of people are afraid to come see us. So will medications change my brain chemistry? What do you guys think? What's the answer to this question? See some head nodding, some twisting. Anyone willing to speak with their mind on this one?
I mean,
Kind of, yes.
Yeah, the answer is yes.
Isn't it?
Yeah, the answer is yes. It absolutely will change your brain chemistry. You know what else will? Any other medication you take, a vitamin, a quesadilla, like a conversation with a friend. All of these things are constantly changing our brain chemistry because our brain chemistry is constantly changing. I think the underlying question that's there sometimes is it permanently changing my brain chemistry? And the answer to that is no. So these medications do not have a permanent impact on the brain. And in fact, that's why we see when you stop the medication, the impact that you were having goes away. And so, this can be a way to help people to understand that, like, we don't want to fall into a reassurance trap. You'll be fine. You'll be fine. No, it's not going to do anything, right? Because as with most things in OCD, people are really, really worried about that little bit. And so we say, like, yes, it does change brain chemistry, as do everything else that you do in life. It's the effect of the brain chemistry change is actually less so than psychotherapy, which actually has a longer lasting effect on your neurocircuitry than medications do. But we are intending to change your brain chemistry because otherwise, what are we doing here? Right? We're trying to provide relief, and relief is a change in brain chemistry. So that's one of the conversations that we had to try to just like normalize changing brain chemistry as constant, but it's not permanent. How about this next one? Will they change my personality? What do you guys think? I'd love to get interaction. So someone who hasn't spoken yet, why don't you unmute, be brave. I'll call on everyone eventually. Let's do this. Will it change your personality?
All right, I'll go for this one. I think I'm inclined to say that it probably won't change your personality, like who you are, your values, who you are is deep in your core, but it might just help you manage some of the things that are getting in the way. Help you with, taking, I like my little key phrase is like it takes the edge off of some of the, symptoms that you're having so that you might be able to do some of the things that you want to do that are in line with your personality, but maybe that you're avoiding or not able to do because of some of these symptoms that are getting in the way.
Yeah, that's excellent. So the answer to this is a little complex. It's kind of like a maybe or like a sort of. To your point, exactly, it's not going to change your values. It's not going to change like how you experience things in that regard. But to the extent that anxiety and your anxious behaviors and thinking feel like they're a part of your personality, well, that will change, right? There are some intentional changes. And to the extent that feels like that's part of your personality, like, yeah, that could be different. And sometimes people do really feel that. And it comes up with like how they're motivated to do things, for example. But any sort of changes, which I do like to be transparent, like sometimes people can have that feeling of being kind of like zombie-like or something, like they just don't feel as much. To the extent that that feels like a personality change, we don't want that. That does not happen most of the time. And if it does, we stop the medication or we switch and it goes right away. So if you had some undesirable feeling of change in your personality, then we stop. Right? And so that is not our goal, change our personality, and that's not something that can permanently happen regardless. All right, excellent, Michelle. So now, next question. Do I have to be on medications the rest of my life? Who wants this one?
No, you do not.
Can you say a little louder?
Yes, no, you do not have to be on them forever. Although I did attend one training where they said something like if you do get to kind of like the clinical dose and then decide to go off of that, it may not be as effective if you get back on it. I don't.
That's interesting. That's not something that I have seen before, either clinically or in research, but I was trying to stay open to possibilities. So, sorry, I'm just making one change here. It's bothering me. There we go. Sort of, but not quite. There we go. So, you know, are there patients who are on these medications the rest of their life? Yes. Why? Because they choose to be, right? They've decided that for them, they would rather be on the medication and have the experience they're having on the medication than off the medication. This is definitely not a lifetime commitment. And so the metaphor I use here, and I stole this from another physician who was sharing this at the IOCDF conference actually, was we're not marrying the medication, we're dating. Right, so we're gonna go on a couple dates, we're gonna test it out, feel it out. If we get in a couple of fights and it doesn't feel right, then we're done with that one, right? And maybe we'll go over and take a break and just need some time off, and that's fine. Or maybe we'll go right into Tinder and start swiping to the next and seeing what it's like. But this is not a lifetime commitment we're talking about here. It's not a short-term fling, right? Like if you wanted to just have something quick, this would not be it. These medications take a while to work, but this is not a lifetime commitment. And a lot of people worry about that, which leads into this next question of like, am I going to get addicted, right? This is the thing that sits behind that a lot of times is like, am I going to have to take this medication because I'll be addicted to it otherwise? Who wants this one? Alexandra?
I would just say that, I think of addiction as some sort of behavior that creates problems, that causes some sort of bad effects. And if you're taking the medication and it's really improving symptoms, then that wouldn't fall in that category. But I don't think you would see when you taper off a medication very thoughtfully, you don't see crazy withdrawal symptoms and tolerance. Maybe you do see some tolerance effects. I'd love to hear your answer to that question.
Yeah, that's great. That was all correct. That was all correct, right? So definitely it's not causing the kind of life-destructive experiences. And beyond that, you don't develop tolerance. So, the way I describe this to patients, and that you can feel free to use if it's helpful, is there's kind of three broad groups of medication in the world. There's medications that work like antibiotics, where you take like a 10-day course and then you're cured. And we have nothing like that in psychiatry, sadly. And when I tell that to patients, there's often a little giggle or whatever, and they realize like, oh, that is kind of what I was hoping for. And then I reaffirm that like, I wish there was, and hopefully there will be someday. That is not an impossibility, but right now we don't have it. So there's nothing I can give you that you can just stop taking and the problem's gone. On the opposite side of the spectrum, there's medications like Vicodin or fentanyl, where there's a role for them because they're powerful at doing what they do in order to help alleviate acute pain in this case. But they do have a lot of risks because you start to develop tolerance. You start to feel the need for it. You are in a worse shape than before you started when you stop if you take it for too long, because then you actually have like your receptors in your body have actually been permanently messed up. There are some medications in psychiatry that are like that. And we have to be very careful with them, although there are certain times we use them. And that includes things like Xanax or Valium. But that's not what we're talking about for first-line treatment for OCD. What we're talking about is much more like a blood pressure medication. So if you're taking a blood pressure medication, you take the pill and your blood pressure comes down. And when you stop taking the pill, your blood pressure goes back up. And if during that time that you're taking the medication, you work on losing 50 pounds and change your diet and start exercising a bunch, you may be able to go to a lower dose and have your blood pressure stay the same, or even go off of it entirely if you're lucky and have your blood pressure never go up again. Many people aren't so lucky, so they'll do those things and they'll still have some challenges when they go off of the medication. Blood pressure is high, but maybe not quite as high as before. And so for those people, many of them will choose to keep taking the pill anyways. And that is like what we're talking about here. When you take the pill, it works. When you stop taking the pill, it stops working because it's no longer there to treat, and it just unmasks whatever's underneath. And so you're no worse off than before you started. You didn't build tolerance, you didn't build dependence. It's just you're no longer taking the treatment. And if during the time you're taking the medicine, you dive into psychotherapy, you end up with a less stressed out life or set of circumstances, you may find that you go down on the medication in the future or off entirely, and you're okay. For many people, symptoms come back because OCD is a chronic illness. And for some people, they can manage that just with psychotherapy and choose to, and other people choose to stay on the medication. And that's a choice that your future self will make. It's not something you're deciding now. Any questions about these kind of commonly asked questions and how to approach some of those answers? I hope that was helpful. All right, we'll keep going for now. Actually, while we're on the slide, are there any other commonly asked questions you get from patients? We'll come back to your questions at the end, but any other commonly asked questions that you guys get? Yeah, Kate.
One question that I have is what your recommendations are in terms of for how long might you give medication a try before you jump ship and switch to another medication? I think especially in the context of OCD, I think, and in people who might be apprehensive about taking a medication, there could be a lot of monitoring, a lot of checking, a lot of like, is it working? Is it not working? It's making me feel funny. Is that by design? And so, yeah, I'm sure later on we'll get to this, but I'm very curious about what your recommendations are for patients in terms of, not reducing then monitoring and checking, and then also kind of general guidance on how long you might, stay on a medication before deciding to discontinue.
Absolutely, absolutely. So we'll definitely come to the monitoring, checking stuff piece as well. But in terms of the question of how long, the answer is a while. What I talk to people about is like, if you want to know if it's working, and I will catch people there are sometimes people who come in, they're like, I want to do the full dose. It's been so long. Let's just go to this. And I'm like, well, we could also end up self-sabotaging because the meds are scary. And so we kind of want them to be scary and have side effects and go off. But if you really want to know, is this medication going to do something helpful for me? It does take a while because it typically takes at least 4 weeks after you get to your target dose to know if it's working. And your target dose could be, let's say it's Prozac, anywhere between 20 and 160. And so what we do is we take a judicious, gradual approach. So we reduce the risk of side effects to marching up to a dose that works for you. And the vast majority of people do receive quite a bit of benefit from these medications when you get them to the right dose. And that is different than depression. That is different than certain other things that we treat in psychiatry, where people end up having a partial response pretty commonly, or a lot of people don't respond. We have high levels of response from these medications if we get to the right dose. We'll talk about dosing, we'll talk about side effects in a minute. And actually one thing that people, in terms of length of time, that some people used to say is like, oh, you need to be on medication for a year or two to know. And I don't talk in those terms. And actually the research has been debunked around that in terms of if you're on it for a year or two and then stop, your odds of relapse are lower or whatever. That's actually untrue. It's just when you're taking meds, they work. When you stop, they stop. But also it's really just about getting up to the right dose, not about like how long you're on it in total. Once you're at the right dose and it's working, if you want to stop it a month later, you can. Now you know what it's like. And for many people, they do if they don't like the side effects, but usually then we're talking about other medication options. All right, some tricks of the trade. So these are the things that you would get from a subspecialist that you don't get from most psychiatrists, certainly not from a PCP. So the first is, many of you may already be aware, is that for OCD, when we're dosing SSRIs in particular, or really serotonergic medications in general, we will very commonly go above the FDA-approved max. And that high dose max limit is set for depression. And so that's what it originally came about for. But many years of clinical practice, research have all shown that actually for OCD, you often need higher doses. And so I'll give people a heads up that, we will, for depression, we start at 20 and we go up to 80. For Prozac, as an example, we will go up to as high as 160 for OCD. For Lexapro, it's 20 for depression, up to 40 for OCD. But we're going to try and find the lowest dose that works for you. So that's one thing that a lot of psychiatrists get freaked out about. If you send someone to a non-OCD psychiatrist, they're unlikely to do that because we don't do that with most other medications. And there's a lot of freak out people have around that, but there's lots and lots of evidence to show it's very, very safe. There's not like a risk of serotonin syndrome or anything like that associated with just going up on reasonable pace and monitoring. The next one, and this is even rarer to find, and I absolutely love doing it, is liquid titrations. So as I mentioned, a starting dose for Prozac would be 20 milligrams, just as our example medication. They make a 10 milligram capsule. And so for somebody who's nervous about medications or is like a bit somatic with their anxiety symptoms, you might want to start them on a half dose. And so I will do that sometimes. Better yet, if someone's really nervous about the medication, or they're very side effect prone in the past, or they're very somatic or having like a lot of panic symptoms, that type of thing, we can start with a liquid version and have them take a single drop of medication the first day, which is the equivalent of 0.01 milligrams of Prozac. And so I do this very frequently, more than I do even the like low capsule dose. I probably start like one new patient a week on this. And what you do is, or what I would do is you have them take that first drop, and then the next day, if they're really freaking out or they're having side effects, and I do warn them, like you may well still have side effects because the mind-body connection is super strong, but they will not be coming from the chemical because this amount of chemical is not enough to do anything in your body. It's not enough to like touch a single receptor, basically. And so this helps us get through that initial freak out period and work the medicine into the system much more gradually and help the patient to feel much more at the helm. And so day 2, if they're feeling up for it, they go up to 2 drops. If not, they stay at 1 drop. Day 3, they go up to 3 drops. Day 4, if they're feeling like, okay, I'm frustrated and bored, because guess what? This medicine is not going to work until we get way, way higher than where you're at now. Then maybe they hop up to 1 milliliter. And then the next day, maybe it's 2 milliliters. And the next day, maybe they stay there. And then the day after that, 2. And then the next day, no, I'm ready for 3. And so they get to decide when they go up day by day. And I provide them a range from 1 drop up to 5 milliliters for most of these medications is like the normal starting dose. So they have this whole range to work within. And what I tell them is by the next time I see you, you can be anywhere in that range. Okay, I have no stake in this. This is affecting your life, not mine. If you want to try this out, if you want to give this an exploration, you've got this whole range to play with. You could go up to the full starting dose tomorrow, or you could be at 1 drop when I see you in a month. You could be not taking it all, and that's also okay. I'm not here to judge. I'm just here to answer questions and try to help you feel empowered. So this works super, super well. I don't know if any of you guys, maybe just by show of hands, have you had any of your patients that have done this or shared that this has happened? Yeah, it's very rare that people do it, and it kind of, I think a lot of psychiatrists just don't know that there is a liquid version. But what does this sound like to you guys? This approach that might be more familiar in your guys' world?
A hierarchy.
Yeah, exactly. This is an exposure hierarchy, right? We're doing exposure with the medication. What we're doing with the liquid version is we're throwing a whole bunch of steps on that ladder, right? So we're just giving a lot of flexibility because actually the starting dose of most of these medications does cause a spike in anxiety, which we'll talk about. And that's just too much for a lot of people to be able to handle. And we definitely don't want to scare them off. For a lot of folks, this is like a first impression kind of thing. And I'd rather them be bored with it and take a slow process than be scared away. Augmenting medications.
And I just had a quick question about the, so this liquid option is available for any of the medications that clients could potentially start on?
Not any, but most. So Lexapro, Prozac, Zoloft, those are the 3 that I use it in. But there are others as well.
Okay, great. Thank you. This is the first I've heard of this option. So it's really good to know this.
Yeah, I hear it a lot. Yeah, go ahead.
Thank you. And do you get people going up and then down and then like checking in again, like, oh, I have a stomach ache, and so maybe I should go down. And then again, that constant adjustment might.
No, not normally. So I think I've only had that happen once. So people usually don't. And part of that is the way I phrase it. I say, like, take your time. Like, this is, only go up when you're ready. And what happens is they really like spend more time on the like, okay, like, can I please, I'm kind of bored. I'm just sitting here. They're like, I'm taking this medicine that I've been freaked out by anyways. They're not yet having any body reactions at that point, or they've gotten through the nocebo side effect, as we call it, portion at the start. And now they feel like they want to pull forward, right? Because they're not being pushed. They're like, if I'm having to deal with this thing anyways, then I want to keep going. So actually, very often they're the ones who are pulling forward and ready for the next thing. And if anything, I have people reach out for an extra visit in between early because they're like, okay, I want to go up. So it really flips things. It's not unsafe to go down, but it's not great to have the ups and downs because you can get a little bit of withdrawal. So it's certainly not a way that I pitch it to them either. I really do have it be like, we just crank our way up. And if you're having side effects, you wait it out, right? So we take the same amount the next day and the same amount the next day, and we wait for it to pass and before you go up. So that's the way we talk about it. These are great questions. Other questions here? All right. Oh, sorry. So augmenting medications. So just a word on this, because I don't want to get too buried into the details, but certainly serotonergic medications are not the only medications that we consider for OCD. It is most of it, like, so I would say 90% of my patients for OCD, the only agent I'm using is serotonergic medication. But we do sometimes find that more is needed. And so, our algorithms kind of go like, we try an SSRI and then another SSRI, and then maybe clomipramine, which is work a little better, but has more side effects. And then we start to think about like, well, if you've got a partial response to the SSRI, what do we add on top of that? But I would say that most psychiatrists go to that too quickly and before we've maxed out the serotonergic medication. So I'm always going to try and get someone up to the highest possible dose, unless we're dealing with side effects that they're having on multiple serotonin medications. And then we have to think about, okay, can we do a lower dose and augment? And the augmenting medications, augmenting just being like a medicine you add to boost the effectiveness of the first one, would be like memantine, which is actually originally a medication for Alzheimer's disease that focuses on glutamate receptors, so a totally different receptor in the brain, and has actually had pretty promising evidence in OCD. So I've just started using this, so I don't have a lot of firsthand experience with it yet, but the studies have actually been like quite compelling. We can also use clomipramine, which is that old school antidepressant on top of an SSRI. That seems to work for some people. Then there's the old school, not old school, but the old approach was antipsychotics, specifically like risperidone and eventually Abilify. Turns out they actually don't work as well as we'd hoped. So those are now actually kind of like third or fourth line. But they can be helpful for some folks, but they have a significant side effect burden too. Usually you guys don't really need to be having conversations about those with patients, other than if they say like, is serotonin or SSRI is the only option? No, but it is most of the option. And we have some things that can help. All right, so side effects. Eek. So the big lesson that I try to go through with folks here, and actually for me in my workflows, I actually have some videos that if people say that they're interested in learning about SSRIs, they actually get a video that goes through and explains all these things before the visit even starts. And there's really kind of two groupings of side effects. There's the ones that show up at first and then go away. And then there's the ones that creep in later and tend to linger. So the initial side effects that we often see, which also, by the way, can show up during dose increases. So like even if someone's been on a stable medication for a year and they're not having side effects, if we like went up too much all at once, these can pop back in and then they go away again. But that includes things like dizziness, which is not associated with like falls or lightheadedness, by the way. I've had patients ask about that. A temporary increase in anxiety, which is another one that a lot of psychiatrists seem to not be aware of, but it's well documented and I've seen it many times. I think it's increasingly commonly known, but there really is a temporary increase in anxiety that you can get. That's another reason I guess I didn't emphasize that, but when we're talking about those low dose titrations going up gradually, it not only, it helps us to deal with like, okay, this was a nocebo side effect, something that came from the fears in the brain and not from the chemical. It helps to separate that from the actual chemical induced stuff, but also it just reduces the risk of the chemical induced side effects. So they're much less likely to have this increase in anxiety or the dizziness, et cetera, if we're starting really low and going gradually. But that increased anxiety can be significant. I've had patients who've gone to ERs with panic attacks in the past. This is patients who later came to me and were like, oh no, I could never start an SSRI. This is what happened before. And it's like, okay, what was the starting dose? It's too high. Loose stools and diarrhea, as well as nausea, are fairly common. Usually not diarrhea, it's usually more like loose stools and some cramping that doesn't tend to be painful, and then nausea. And that actually is because our gut is full of serotonin receptors, which are the main receptor, of course, that SSRIs work on, serotonin reuptake inhibitors. So and the reason that our gut is filled with that is interestingly because as an embryo, the brain and the gut actually come from the same part of the embryo. So they just have a lot of the same components to them. So the gut initially is like, whoa, what's going on as all these receptors get hit? And those are what we see most commonly, but it adjusts pretty quickly. And then headaches is another one that we see relatively commonly. It's something like 12% of folks. All of these side effects go away usually within days, sometimes a week or two. I have had people that have just had like ongoing nausea. That's something that can sometimes linger. For those folks, I usually encourage either take it, with food is helpful. Sometimes taking it at night so you sleep through the nausea works. And also ginger helps. So we have ways of working this through with our patients. The later side effects are the real bummer to me. And so those tend to show up around the time the medicine starts working. They are often dose related. So the more we go up, the more likely they are. And they will usually decrease a bit once you're on a stable dose, but they don't always go away. The most common of these being sexual side effects, which are very common, which is usually decreased libido and difficulty achieving orgasm, both for men and for women. These side effects are different levels of risk between the medications, and we'll talk about that, but it's one of the things that we definitely think a lot about because it's a real bummer when people have this. A lot of patients just don't care. They're kind of like, oh my gosh, thank God, I just feel so much better. But then eventually we really try to like, okay, you're doing well enough now, you've done more CBT, maybe we can pull the dose back a little bit or try a different medication and see how you do. Some people just like react to it on one medicine and not another. Weight gain and appetite are also a problem. This is usually like 5 pounds, but depends on which medicine. But that's like on average. So some people have none, some people have more. So it can be a real problem. Fatigue, especially with certain medications, sleep changes can be insomnia or sleeping more, sweating at night, jaw clenching, and vivid dreams. I would say sexual side effects I see very commonly. Weight gain I see commonly, and it can be managed in most people. Sexual side effects, it may be even like 50-50 weight gain, maybe like 35% of people I see have something like that if they're not careful. Fatigue, it tends to be really dependent on which medicine, and sleep changes also. So I usually most of my patients don't have fatigue or sleep changes or sweating or jaw clenching, just because of what choices we make, but they are possible. And then vivid dreams tend to be something that just kind of startle people because they're like, wake up and it takes a while to realize that was just a dream. It felt so vivid, but they're not. Sometimes they're nightmares, but often not. So it's more of something to get used to. But for some people, it can be distressing. And so usually I also, for some reason, see that go away when we switch medications. Key point here. So I like to have you guys have some level of awareness. And some of these you may already know that people can have and experience. 2 reasons for that. One is because, we do like to be transparent and honest. Like one of the things that I have to do is, when people seek reassurance, so I won't have any side effects, will I, or that type of thing. Like it can happen, but, we try to move away from a sense of permanence. And that's why I have this last point in here, which is that these are all reversible. So when people stop medications, these go away. The only ones that don't, and I warn people around this, is first of all, there's some literature that shows the sexual side effects may linger a little bit for some people, but that's not been my clinical experience, other than people who've like aged 10 years in the process. So now they're just older, but who knows? There is some evidence maybe that lingers for a little bit. But the other one is just the weight gain. Like if you do gain weight, most people don't just like drop the weight when they stop the medication. And so I encourage people to be checking their weight regularly when they start the medication. And usually we see that start relatively quickly. And so we can catch it early. Other than that, this all goes away. So when people worry about side effects, I'm like, yeah, side effects, we stop. Or we try something else. Just to make it clear that like there's not this huge pressure and it's not a sense of permanence. Any questions on the side effect side of things? Side effect side. Okay. All right. So SSRIs, which one do we start with? So I would love to hear from someone we haven't heard from yet. Maybe Allison, put you on the spot. What has been your experience of like why psychiatrists seem to have chosen one of your patients to go on one medication and one another? Like, do you have any sense of like what the patterns are?
Like, no, most of my clients have not. I think off the top of my head, maybe 2 of my clients have been placed on medication and they
Oh,
were
okay.
placed on Lexapro.
Okay.
And one switched from Lexapro to Prozac due to side effects. And
Okay.
that's been my entire experience.
Good. I mean, actually, that starts to hint at what we see, which is that side effects end up being a major reason for deciding between them. So, so the first thing we think about when we're deciding which SSRI to start somebody on, and part of the reason I ask that question is because I think a lot of therapists have the experience of like there is no clear pattern, or it just seems to be which provider it is, like just favors one versus the other without clear reason. And I do think there is unfortunately quite a bit of that. Certainly in my practice, I try to be more evidence-based than that and have a little bit more reasoning behind it. And so that's what I'll walk you through in terms of how, it would be best to think about this and how someone practicing appropriately would think about this for the OCD population. And so one of the first things that we're meant to think about is the previous trial history. So if they're new to treatment, that's different. But if they've tried things before, that's the most important thing to understand. Not just what have they tried, but how long did they try it for? What dose were they on for the trial? So that we can first gauge, was it an adequate trial? Do we like take in that data as being representative of whether it worked or not? And then if they did have side effects, were they those early side effects? Did they get scared off? Was the dose started too high? So really trying to understand the previous trials better is going to be the biggest informant to the future because people's past responses are the largest predictors of future responses, good and bad. Additionally, family history is really important. So if somebody has family members who have been on SSRIs, or other related medications, and they've had good or bad responses in their genetic family members, I should emphasize, research has shown us that those are big predictors of someone's response. So if you have a family member who did really well on Lexapro, then you will probably do really well on Lexapro. If your family member did really poorly on Lexapro and did really well on Prozac, you will probably do poorly on Lexapro and well on Prozac. So that's a good one for us to learn about. Then it comes to side effects. And so I've listed out here some of the differences. Certainly, wouldn't imagine you necessarily need to memorize these, but it can be good to just know that there are actually some differences between the SSRIs. In general, they're pretty similar across the board, and they share all the side effects we were just talking about. But these are some of the standout differences. So for Lexapro, and I would say Lexapro and Prozac are the 2 I prescribe the most as like first line. So Lexapro works very well. I sort of describe it to people as kind of putting water on the flames a little bit. It kind of douses the fire. But it does tend to result in more weight gain, more lethargy, more sexual side effects. So like the classic thing with Lexapro is people just will nap more. They'll just say like, yeah, I just like, sit on the couch and then, wow, I woke up 30 minutes later and I didn't used to do that. Right. So it's just that little bit of like, just kind of feel tired during the day. And weight gain is definitely more likely, and the sexual side effects are definitely more likely than, for example, Prozac, which has less of each of those things, less risk, although it can make people feel a little bit over-caffeinated. So sometimes people will feel kind of jittery or even have like a little bit of hand tremor. Usually if they're having tremor, then we stop. But if something else, we don't want someone to deal with that. But it tends to be more on that side. It also has a long half-life. So I have had a patient this year actually who developed a rash on Prozac, which you can get a rash on like any medication, but it was like very itchy, poor thing. And like the downside was, has such a long half-life. The half-life is 2 weeks long, which meant that like 2 weeks later, she still had half of it in her system. So it took a long time for the rash to go away. So that's like a thing that we consider as a downside. It's also a potential upside though, because most people tolerate Prozac super well. And then if they like go out of town for the weekend, forget their medicine, they don't go through withdrawal, because the medicine's like just starting to work its way out of their system. So a lot of young people, especially, I'll think about Prozac if they're like college students or whatever, because they're just like notoriously bad at taking pills every day. And so that can be really nice because the up and down is not great. So Prozac, usually my first line, Lexapro number 2. Zoloft, Zoloft is a good medication. I rarely start people on Zoloft, and it's for one specific reason, which is the sweating at night. It is very much a dose-related side effect, and it's one that a lot of psychiatrists don't seem to know about. I had to learn about it the hard way in residency when I had someone that had a little sweating on an SSRI, and I switched them to Zoloft, and the sweating got so much worse. And it turns out that it's the most likely to do this by far. So much so that pretty much anyone with OCD, because we're often going to these higher doses, will end up having a lot of sweating at night. Now, I definitely have patients who came to me on Zoloft who are like, that's fine, like it doesn't bother me that much. So that's common. But I've also had patients who have to wash their sheets every day because they get like a puddle of sweat. So that's not great. But we can do things to try to help with this, like literally just like keeping the room cooler at night does reduce this side effect. So if there's, because it's like a heat sensitivity feeling as well. It's not just that there's sweat coming out of your body. So that can help. And then Celexa, we rarely use for OCD anymore. I would never start someone on Celexa for OCD, and that's because there's this black box warning on it for QT prolongation, which is basically like a theoretical risk for a heart problem in the future. And that only happens at high doses. But again, with OCD, we often like to go high. So why start a medicine if you're going to be stuck and not be able to go high enough? Either that or we have to get EKGs and stuff. And most of us think this is way overblown. Like there's not actually a single case report known of someone having this heart problem on Celexa, but it is what it is. Now that there's this warning, we just don't deal with it. And then Paxil works really well, lots of side effects, don't deal with it. But notably, efficacy was not on this list. So we are not choosing SSRIs based off of which one we think is going to work best. Even though I said like Lexapro kind of puts some gas on the flame, so to speak, like Prozac still like really reduces anxiety and OCD just as well. So it just doesn't have that kind of like chill fatigue side of things like Lexapro. So the only exception to that is clomipramine, which is an old school antidepressant, which you may have some of your patients started on. It's also known as anafranil. And it basically has a little bit better efficacy, we think, like it works a little bit better. But it has a pretty significant side effect profile. People get like blurry vision from dry eyes, dry mouth, can feel a little foggy. So that's typically like our third or fourth choice. Any questions on this one?
Yeah, I have a question. I've had a couple of clients who've been put on Luvox. I'm wondering if you could speak about that medication.
Yeah, so Luvox, I rarely start people on. It's worth revisiting these days, but it's fairly similar. It's kind of middle of the road in terms of SSRIs. It might have some more GI side effects, so the kind of like nausea or loose stool stuff might be a little bit more, maybe less weight gain and sexual side effects than Lexapro. The reason that myself and other OCD specialists, like if you see someone started on Luvox, it's almost always started by a non-OCD specialist. And that is because it has an FDA approval for OCD. So it seems like the obvious choice, but it turns out that literally just means that the pharmaceutical companies like did the research on OCD instead of depression. And so they got the approval for OCD instead of depression, but has the exact same mechanism of action of all of the other SSRIs. So it is just an SSRI, an antidepressant like anything else. You could use Luvox for depression, even though it's not approved for depression, it would work just as well as anything else. The reason that we don't do it as much is because it's always been more expensive, but it is getting cheaper now. And so it's something to like revisit around these days, but there's nothing to make us think it works any better. Excellent question though. Yeah.
And what are your opinions, or what do you say to people who come to you and ask about, personalized genotyping to make medication decisions? Do you give any credence to that, or yeah?
No, absolutely not. So for those of you guys who know about these genome testing, like the idea of it's nice. There are specific use cases where I would consider it. Currently, if I get a patient who does it, I read it out of respect, but it almost never changes my treatment. And that's because these tests were designed to be able to look at how we metabolize medications differently. And I think the one thing that really changed my perspective about these coming into kind of the prescriber zeitgeist is that it turns out we have a lot of differences between us as people. Like we actually do metabolize medications differently. Like many people have various variants of our genes that cause us to increase our metabolization of certain medications and decrease it of others. But the reality is many studies have been done that show that if you introduce these tools into psychiatric care in any setting, they do not improve clinical outcomes. And that's the big picture questions. Do they improve care? The answer is no. And so that is like almost the like done period. We're over it. The other piece is that where it could help you is to think about like, okay, like If somebody is a rapid metabolizer, you might need a higher dose. Or if someone's a slow metabolizer, you might need a lower dose. But as I already said, we're already trying to start low, go slow, reduce the risk of side effect, find the lowest dose, but keep going until we hit success. And that is still the case regardless of what their profile shows. So the clinical picture is what's guiding things no matter what. The only folks I consider it for are people who have like a really weird, wonky history of medication trials with a lot of medications. And if we look at it and we see that that pattern is consistent with the genetic profile, then I would take credence to it. I think I've had one of those ever. So it's very rare, and in fact, the studies have shown that. So we don't, I never order it anymore. All right. So yeah, that's a segue into Q&A actually. Looks like we have about 9 minutes. So let's open it up. Questions?
I have questions. So one of the questions that I always, or issues that I say, or when people are, for example, I have a patient right now who's working with another psychiatrist, and after a couple of medication trials, was started on a benzo and is absolutely loving it. And this is a new lease on life. And I feel so uncomfortable with this as the long-term treatment strategy, but also don't feel like it's my place. I'm curious what your thoughts are on benzos as a long-term, or even, how you see benzos in the picture of clinical practice these days.
Yeah, absolutely. So, yeah, obviously you saw my face. That's not typically great. I don't know the case, so you never know. I would say, like, well, I think it's all of our places to use our knowledge as best we can and then recognize our limits. But like it's also perfectly acceptable to be like, hey, like I think maybe a second opinion could be helpful. And this is my concern with working with a subspecialty disorder without a subspecialist, is you get this type of prescribing patterns. So the biggest problem with benzos, which many of you know, is in this particular line of work that we don't see in other uses of benzos, is their interference with extinction, habituation, distress tolerance, any of that stuff when it comes to things like exposures, whether in vivo, in vitro, whatever. And so that's especially the case with PRN, as in like as needed in the moment benzos. So there are situations in which I would start someone on a long-acting or longer-acting benzodiazepine when I initiate an SSRI. So somebody who's like really high levels of distress and alarm and panic, et cetera, and they've never been on meds, they're terrified. We could do what's called a bridging medication, where we start something like clonazepam. I'll have them take it every single night, so not as needed. So it's not like a response thing, avoidance thing. It's just a baseline that we're putting in their system. It lasts 24 hours plus. And so it's there for a while. We have an agreement ahead of time. This is going to be for 1 to 2 months only. And that if they feel like they still need it at the end of that, we will raise their level of care, but we will not refill the medication. So it's really important to have really clear bounds, because if there's any ambiguity, then people feel the distress of the ambiguity and try to push against it. But if it's just, this is what it is, we have a relief valve, which is higher level of care, but it's not more medicine, that helps. But yeah, I mean, like, if someone's having trouble responding to SSRI and you throw in an Ativan that they get to take just when they need it, okay, well, of course they love it because they've just got their avoidance mechanism. It's just a new one, right? Because that's all we're talking about here, is like, this is the wave, and the Ativan just yanks you right down, and that feels great. And then you feel like you need it, right? You're now psychologically dependent on it in addition to any sort of chemical dependency. So yeah.
And just as a follow-up, how do you address other medications, non-benzos, that are still used in that kind of anxiety reduction means? Like, I'm going to take gabapentin, I'm going to take, my clonidine, but I'm going to use it in response to feeling anxious, as opposed to, at a set time and place. And
yeah, I mean, so it's kind of the same thing, but with less risk. So like if someone were on an Ativan and they decided to switch to gabapentin, I'd say, okay, harm reduction, we're headed in the right direction. But I mean, if anything that is taken in the moment to reduce distress is going to perpetuate. Again, there can be short-term applications sometimes. Like the one time that I will use a PRN, or like prescribe it like an as-needed benzodiazepine without much hesitancy, is for flight phobias. And it's because it's just so contained And as long as someone's not like a business traveler that's traveling every week, if they just like don't want to take on doing exposures around fear of flying, like I'm kind of like, that's fine. Here you go, 10 pills a year, have at it, you know? But if they're traveling every week and this, or if they just like want to get over this fear of flying, well, this is not going to help, right? So we don't do it in that case. And so yeah, so gabapentin, hydroxyzine, these are medications that can be taken as needed. Sometimes they're more standing, and so then it's less of a concern. So gabapentin could be twice a day, and there are certain times when that could be a helpful medication for people. The only time it's bad in OCD would be if they're not optimizing the serotonergic medications and instead doing gabapentin, because gabapentin does not have good evidence in OCD. But other anxiety disorders, there is actually some evidence. Pregabalin may be even better. Other questions? We have time for one, maybe two.
I was gonna ask about hydroxyzine, but you just kind of mentioned it because I do see that one, and I'm much less concerned about that one just because it doesn't have some of the addiction properties and those type of things. But I was curious your thoughts on that. And then also, I often see Wellbutrin as an adjunct medication, and I wanted to get your thoughts on that one as well.
Yeah, great questions. So hydroxyzine is an antihistamine, so it's really not so different than Benadryl. It's a little bit more pure antihistamine than Benadryl, which is got a lot of anticholinergic part, which is why if you like take a Tylenol PM, well, Tylenol PM isn't always Benadryl, but some of those others you get like foggy feeling, like that's actually from the other receptor. Mostly makes you not anxious by making you sleepy. And if you think about fight or flight, what's the opposite of fight or flight? Rest and digest. So if you bring some over to this side, then they're not going to feel as anxious because they can't be, they're over here. But people going about their day being sleepy isn't like great. So it's not like a great daytime medication. It's mostly used in settings where like, we're trying to avoid giving someone a benzo and are having trouble doing that. And so we'll do something like hydroxyzine instead. So it's kind of like a harm reduction thing. But doesn't work super great, has the sleepiness, and ultimately if they're taking it in response to stress, perpetuates the cycle. Wellbutrin, bupropion, used to be talked about as like, do not use for people with anxiety disorders. False. It turns out that like SSRIs, it can increase anxiety at first. And so it used to be that was the reason we wouldn't do it. But they're like, wait a minute, SSRIs do that too. And actually it goes away just like it does with SSRIs. The difference is with SSRIs, your anxiety then goes down further. Bupropion, there's like some evidence that it might do that for a small group of people, but for the most part, that's not the case. And so I would pretty much never start someone on bupropion for an anxiety disorder, but I absolutely start it for people who either have depression or maybe some ADHD can help with that, but not much, or need a little energy, it can help with that, but again, not a lot. More so just if you have depression.
Thank you.
And Alexandra, did you have a question as well?
Mine was actually about Wellbutrin as well, so it's answered.
Perfect. All right. Any other questions?
I had a question. I was curious. So if a client like misses a dose of one of these medications or maybe like a week's worth, would we expect they would start to feel some of those symptoms again, like if they ran out of medication, or how quickly do those anxiety symptoms tend to return in that type of situation?
Yeah, great question. So it depends on the medication. First of all, you can get withdrawal from SSRIs. So Paxil, notorious for withdrawal. Effexor, SNRI, really bad withdrawal. Prozac, very unlikely to have withdrawal, but there's a space in between. And withdrawal can be flu-like symptoms, but can also be like irritability, moodiness, tearfulness, anxiety, etc. In terms of the benefit of the medication wearing off, it's just so that withdrawal could be the next day, it could be a couple of days later. In terms of the benefit of the medication wearing off, that actually usually takes weeks to months, just like effectiveness does. So like OCD symptoms reflaring doesn't usually happen within a week. And so people say, oh, I stopped, I feel so much better. It's like, okay, if you're having side effects, of course you feel better, but we're not going to know what this looks like for you to be without medication for a month or two.
Perfect. That's helpful. Thank you so much for hosting this. It was really also my first time of hearing about like the tapering up and how you can start with the liquid medications. That's so helpful. So many folks with OCD are just so fearful of even trying medications.
Yeah, I've also, as the last thought, I've had someone who was just so afraid, and it was just like, so the first tip of the iceberg type of thing that I just told them, just take one drop, and that's the only drop I want you to take until I see you next. Don't do any more. right? Just to get that first exposure without it having to lead into anything else that we talk again. In any case, lovely meeting with you all. I hope this was helpful. I'll send out the slides and hopefully a recording. As I mentioned, I'm growing my clinic. So if you have people I can help with, please send them to my website, anxietyreliefclinic.com, and you can also email me. Thanks, everyone.
Thank you, Weston.